Well, first of all, let me say to everyone, welcome and good evening. I have to say, like maybe many of you, this is the first time I've put a jacket on in quite a long time. It was March 9th when we transitioned all of our degree programs here at the business school over to fully remote. So we've all been working at home now also since no later than March 24th. So again, my name is Michael Koenig. I'm Associate Dean for Innovation Initiatives, but importantly for tonight, I am also the Executive Director of Executive Education, and we, along with Kyle, External Relations, Alumni Relations, are really the sponsors of this evening's engagement. So just so you know, there's three of us in this classroom. When we're not speaking, we are wearing our masks and we are using our physical distance appropriately, as we all should be from now on. Let me just say this. Before we get started, I want to talk a little bit about the approach tonight. So as Kyle said, everyone's on mute. We have a very large group. We're well over 100 now. So we would like to solicit those questions. But the way Edward's going to set up his talk tonight is he's essentially has three distinct modules. He'll go through the first one, and then we'll take a break, and I will be soliciting some questions over chat. Second module, a few more questions, but we will try to leave some time at the end of the evening to grab as many questions as possible, but still respect the 60 minutes that we scheduled for tonight's activity. So that's the process. We'll do our best. I won't be able to get to all the questions because of time constraints, but we'll get some good ones each time. So with that, I'm going to introduce to you tonight's talk. We have Edward Kroger. So Edward graduated with his BS in biology from Baylor University. He received his MD from UT Southwestern Medical School, completed a 3-year residency in internal medicine at UT Houston Medical School. He then graduated from the University of Texas School of Law, and then he received his MBA from Rice University, so he is one of our alums in addition. But I think most importantly, what you can see is that Edward can see into the healthcare system and the business of healthcare from very distinct but important venues and views. So the past 20 years, Dr. Kroger served as a founder and managing partner of the health law and health business consulting firm here in Houston. Now he devotes his time to teaching, to consulting, and spending time with his 3 college-age children. So with that, Edward, I'll leave the floor to you.
Okay. All right, welcome everybody. Tonight we're going to try to cover in a very short period of time 3 fairly complicated subjects. So we're going to fly by these. We're going to first talk a little bit about the U.S. healthcare system and some of the challenges that the U.S. healthcare system faces even in the best of times. We're then going to talk a little bit about COVID-19. And then finally, we're going to talk about the effects of COVID-19, the pandemic, on the U.S. healthcare system. So those are sort of the 3 large areas we're going to be covering tonight. Begin with a 1-minute video.
When I was a kid, the disaster we worried about most was a nuclear war. That's why we had a barrel like this down in our basement, filled with cans of food and water. When the nuclear attack came, we were supposed to go downstairs, hunker down, and eat out of that barrel. Today, the greatest risk of global catastrophe doesn't look like this. Instead, it looks like this. If anything kills over 10 million people in the next few decades, it's most likely to be a highly infectious virus rather than a war. Not missiles, but microbes. Now, part of the reason for this is that we have invested a huge amount in nuclear deterrence, but we've actually invested very little in a system to stop an epidemic. We're not ready for the next epidemic.
So for those of you who haven't watched it, the whole TED Talk is worth watching. That was back in 2015. Bill Gates, of course, has devoted his post-Microsoft life to infectious diseases. His subsequent videos are also worth watching for education purposes. The US healthcare system, we sometimes think of it sort of like this: a patient, a doctor, a nurse lying in a patient lying in a bed. But the US healthcare system actually looks more like this. This is a large ICU in Wuhan, China, where they're taking care of COVID-19 patients. Several things to recognize about the US healthcare system. First is its size. It's a $3 trillion industry. To give you some idea, healthcare is about 17% of GDP, 17% of everything that is made or produced in the United States. And by comparison, entertainment is only 3%. 1 in 8 people in the United States are directly or indirectly employed in healthcare. So it's a massive industry. On the bottom right, you have Rice University. Across from Rice University is the largest medical center in the world. The Texas Medical Center is huge. To give you some idea, it would be the 8th largest business district in the United States if it was independently assessed. It's got 18 hospitals, 15 schools, et cetera. So the size of the U.S. healthcare system is impressive. Second is the growth. The rate of growth of healthcare as an industry has been phenomenal. So it's growing about 5 or 6% a year. Medicare spending, same. Medicaid spending, which is for people who are in lower income situations, is growing twice the rate of Medicare. To give you some idea, between the 2000 and 2010 census, healthcare employment grew 25%, while total employment in the United States actually dropped 2%. So it's a massive industry that's growing very quickly, far outpacing any revenue input or spending ability. The complexity is another factor to consider. In a typical medical center, there's about 2,500 medications, 1,100 clinical tests. There are roughly 10,000 diseases that physicians address in the various specialties. Publications are close to 1 million a year. The last time I checked, it was about 800,000 articles published in medicine every year. And of course, specialists don't read all the literature. They focus on their specialty. But if you were going to attempt this would be 90 articles per hour, 24 hours a day, 7 days a week, 365 days a year. So there's no way that any one person can keep up with the entirety of medical knowledge. When I was first entering medical school in 1980, there were 2 types of data available. One was the paper chart, which we see on the left. And in that, we would handwrite our notes about the patient. We would handwrite the lab values. And that's where all the patient information lay. On the right, we would have the medical bill, which was rather simple back in the day. And those were the 2 sources of information: analog, paper, files. Fast forward to 2020, and you're gathering information in healthcare from dozens of different sources, and I've just listed a few. Not all of them are compatible with each other. Not all of them speak with the electronic health record. And the volume of data is overwhelming. Healthcare has started to collect all this data. It still is lagging other industries in being able to figure out what to do with it. But ultimately, the electronic health record and all of this data will be useful to physicians going forward. To give you some idea of the amount of data, the authors of this paper clocked ER physicians during a 10-hour shift and found that 43% of their time was spent mouse clicking. 28% of the time they were actually in contact with the patient. So the amount of data is incredible. Another thing to realize about the U.S. healthcare system is the legal aspect of it. It's the most heavily regulated industry in the United States. There are literally thousands of healthcare-related statutes, tens of thousands of regulations, which put those statutes into effect. immense regulatory costs. Being actually a healthcare lawyer, a health lawyer, a health law specialist is one of the most difficult types of lawyer to be, just because of the massive areas and amount of information you have to be expert in. To give you an idea, the Affordable Care Act was a 2,700-page statute, and it had 20,000 pages of regulations which put it into effect. And that's one single statute. Here's a diagram that someone drew showing how our healthcare system regulates healthcare providers. If anyone can make much sense of this, good luck. But that's actually gives you some idea of the regulatory complexity that healthcare faces. Let's talk about a few of the challenges that the U.S. healthcare system it faces. When you put the United States up against other countries, and multiple reviewers have done this, surprisingly, we don't perform very well. We think about our high-tech healthcare. We are world leaders in developing a lot of healthcare technology, but we don't do a very good job of actually delivering that to the entire population. And so the most recent ranking of the Commonwealth Group puts us in 11th place out of 11. And you can see where we score better at things like effective care. We do a very poor job of cost control and a very poor job of equity, efficiency, and creating healthful lives. The other thing to note is the cost, the expense of healthcare in the United States, which is 2 to 2.5 times what other countries are spending per person on their citizens. Medical errors are a significant problem. This is a Johns Hopkins study that was published a couple of years ago. And they did chart reviews and statistical analysis and found that medical errors were the third leading cause of death in the United States, behind heart disease and cancer. It works out to, if I did my math right, about 689 deaths a day, which is the equivalent of 5 fully loaded airplanes crashing due to healthcare mistakes every day. No other industry sort of tolerates this amount of medical error. It's not the physicians and nurses who are responsible for this. It's the procedures and the mechanisms we have of taking care of patients that need to be improved. I mentioned cost as a concern. This is US healthcare costs. You can see that they are ballooning. So those are in billions of dollars. So by 2020, it's expected will be over $4 trillion spent on healthcare. And as I mentioned, our federal and state revenue is not keeping up with this type of expenditure. So this is not sustainable over the long term. Again, if you compare the United States to other developed countries, we spend about 2.5 times what other countries do on their citizens. These are all adjusted for purchasing power and stuff, so these are real numbers. And multiple reviewers have found similar results. All of this would be acceptable, the high cost, if it resulted in better health care. But this is the most problematic part, that despite this massive expenditure, we are not getting the results that other countries are, even spending 2.5 times as much. So this chart shows health expenditure on the right, and we're an outlier on that. On the left, it shows life expectancy, and we are behind other countries, other developed countries in life expectancy. And you can plot out the same, you can do maternal mortality rates, you can put childhood deaths, you can plot out almost any measure of healthcare results, and we're lagging behind other developed countries. And so the question then obviously is why, and what are they doing differently? So I teach a course on the business of healthcare here at Rice, and one of the first questions we cover in the class is to ask ourselves whether healthcare is even a business. Businesses are in place to make money for their investors, or if you're a nonprofit, to return a healthy amount of revenue back to the system to grow the system. We all feel comfortable saying that the industry on the left, an oil refinery is a business. Probably most of us are a little less comfortable saying that what's going on the right, taking care of a premature infant, is a business. That even if we lost money, we would want to be spending that money somehow on trying to keep this child alive. So it's an interesting question. It probably is a business. It's an unusual one. When a business is not working well, you have sort of basically two choices. Either the government steps in and reforms it in some way and regulates it, or you let market forces fix the problem. For a bunch of reasons, the healthcare system is not a viable free enterprise type market. If you're an economist, you recognize these categories. There are certain things which destroy a market and make it untenable. An obvious one, and I won't go through all these, but information asymmetries. To have a viable market, both the purchaser and the seller have to have roughly the same information so they can make an exchange. And in healthcare, physicians and hospitals have information that patients simply don't have and probably would never have without going to medical school. So there's information asymmetries, there's failures of competition. Another way of saying this, and this is a quote I took from an article that was published a few years ago. They said that healthcare is a peculiar market in that the products and services provided are purchased by relatively ignorant consumers in response to choices made by third parties with funds provided by other third parties. And that the information used for making these choices is often out of date, biased, or partial. All of which sounds like not a very good free market type system. In the class, we talk about whether healthcare is burritos or freeways. If you're in the market for a burrito, you have multiple choices. You know how much they're going to cost, what they taste like. You're free to walk away from your burrito and go somewhere else. You're free to read reviews. And so we're very comfortable having a free market for burritos. For freeways, we've gone a different route. We would not want multiple people competing to build freeways. We simply want a freeway system that works for most people all of the time. And so the government has stepped in and created the freeway system. And it's a very fundamental question to ask in healthcare. Sometimes both commentators and providers want it to be more of a free market. At other times, they want it to be more of a freeway system. Somewhere in the middle is not a very viable position to be. Here's what other countries have done, because you can ask, what are they doing differently? In Britain, the government both finances the care and directly pays all the providers. You work for the government if you're a healthcare provider. And that's what most people consider to be some sort of, quote, socialized medicine, unquote. Germany, the government regulates about 200 not-for-profit insurers, and they pay private doctors. So both the insurers and the doctors are all private entities. The government simply regulates not-for-profit insurers. There are no for-profit insurers in Germany. And the government sort of regulates those insurers. They compete then to win over individuals for their dollars, and then they pay private providers. Canada, the government finances the care, so they collect money from all the citizens, and then they pay private providers. And in Cambodia, you get whatever care you can pay for. There's no organized healthcare system. Nobody in the world among developed countries allows for profit-making healthcare in health insurance companies to be involved in the system. So the United States is unique in that we have large companies that take our dollars, have an administrative fee, and then turn around and pay our physicians. And so in the United States, as people in the United States do, what we've done is we've decided we want all four systems. So for most working people, we're under 65, we're Germany, sort of with paying money in, and then the government regulates insurers, although those are nonprofit healthcare providers, healthcare insurers. For Native Americans and military personnel, veterans, we're Britain, where the Indian Health Service and the VA hospitals are all government run, paid for, and you work for the government when you're a VA physician. For those over 65, we're Canada, where they collect money and then pay private doctors. That's Medicare. And then for the 45 million uninsured, we're Cambodia. You're free game. The hospitals and physicians can charge what they wish, and they collect some of it and don't collect a lot of it. This is an article out of JAMA, which is probably the most broadly read medical journal. And it's striking. It says that the breadth and consistency of U.S. underperformance suggests that the U.S. pays a penalty for its extreme fragmentation, financial incentives that favor procedures over a comprehensive longitudinal care and absence of organizational strategy. So everyone sort of realizes that the system doesn't work well. Of course, everyone's got a different opinion as to how to address it. In general, healthcare providers talk about a triple aim. It's described in different ways. Probably the clearest way I like to describe it is you're trying to fix issues of quality, access, and cost. And the problem is when you fix one of those, you mess up the other two. So if you're trying to open your healthcare system to more people who cannot pay, you're increasing the cost. If you are trying to throw it open to everybody and not increasing the number of physicians in hospitals, you're jeopardizing quality, et cetera. And so for many years, it's thought to have been basically a zero-sum type game. So in the class, we talk about value being equal to quality over cost, which is basically the same equation as you would have in any other business. You want the highest quality at the lowest cost, and that gives you value. And right now, the healthcare system is trying to change from a volume system to a value system. So the volume system is where physicians and hospitals get paid every time they do a procedure or see a patient. A value-based system would be where those entities are paid to take care of a population of patients, and the healthcare provider gets to keep the money whether they do procedures and hospitalizations or not. So there's a giant incentive in that kind of a system to keep everybody healthy. In the volume-based system, there could arguably be an incentive to simply have as many sick people come in the door as possible. And so it is thought by experts that the solution to this is to move to a value-based system. There are a lot of difficulties with that. And I'll show you like a very simple example. Let's say you had a healthcare clinic and you were going to renew a contract with a consortium of large companies, and there were 10,000 visits last year. Under a volume system, let's say they would pay you $100 per patient visit, so you'd make $1 million off those patients. And your incentive would be to get as many sick people in the doors as possible. That's the current system we have. Under a value-based system, the consortium would pay you $1 million to care for their patients, and they wouldn't care how you spent it. You would be responsible for the health of those patients. Now, all of a sudden, you would be all interested in wellness and keeping people healthy. And in fact, you would hope that not a single patient would walk into a clinic or a hospital in your system. You'd try to be keeping everybody healthy. So it's a dramatically different way to view healthcare, and that's slowly where Medicare, Medicaid, and private insurers are beginning to move. In the class, we go into some detail as to what quality and cost are. Those are loaded words. We try to give examples and review best business practices about how you achieve that quality and how you reduce the cost. And so we slowly work out and end up with this sort of equation that we use in the class. And much to your relief, we're not going to go through this tonight, but it's out there. That's what we teach in the class. So I'm going to pause for a minute and maybe take a few questions over what we've covered so far.
All right, so far I have one that comes through. If we don't get any more, we'll move on after this one. But if we do, we'll keep them going for a few more minutes. We have Jasper Cannon, who I think comes to us from Philadelphia, if I remember earlier chat. Okay. He says, for the 45 million uninsured, doesn't the Emergency Medical Treatment and Labor Act cover them for emergencies? Not truly Cambodia, since it still does provide care for those who can afford it.
Yeah,
do you have that right?
That's an excellent question. So That's EMTALA, which the healthcare providers that are watching tonight will know. EMTALA is a federal statute, was passed about 20 years ago. It's an interesting act. It says that if you have an emergency room, you must evaluate and stabilize any patient that walks in the door, irrespective of their ability to pay, which sounds like a good system. What the government did not do was figure out a way to pay for this. So what they did was handed to healthcare institutions a largely unfunded responsibility to care for people who come in the door. So it is true that if you have no insurance and you show up at an ER, they have to stabilize you, evaluate you and stabilize you irrespective of your ability to pay. That doesn't solve all the problems. For one, once they've got you stabilized, they can send you home. And so they're not obligated to provide the sort of standard care that you would normally receive after being seen in an emergency room. Second, many of those patients can't pay, so the healthcare institution is simply taking the charges that they normally would charge these patients or their insurers for and putting those on to paying patients. So you're just shifting the expense around. Third, you're creating an incentive for patients to show up in the emergency room rather than getting preventive care and preventing them from being in the emergency room in the first place. The emergency room is not the right place for much of routine care or preventive care. So the EMTALA created an incentive for people without insurance to show up in the emergency rooms of the United States, and so while they were trying to solve the problem of people being dumped out of emergency rooms, and they did largely solve that, they didn't ultimately solve the problem of people without an ability to pay. One reason this is important, and we'll look at this in a moment, is when we talk about COVID-19, all of a sudden, you may not care whether the person down the street living in a different neighborhood is getting their diabetic care or their congestive heart failure care. You probably do care a whole lot whether they are getting COVID-19. So the current healthcare crisis is spotlighting some of the healthcare inequality in the United States in a way that even if you can pay, you're still probably more anxious about those patients that are unable to get healthcare than you were a few months ago. So excellent question, though.
I have one more question, and then we probably need to move on to the next section. In fact, this may dovetail into the next section. So our own Kyle asked, how do you see supply chain evolving in a post-COVID world? Do you think there will be a shift towards sourcing from multiple countries and making things more here in the United States?
And the answer to that is yes. So we'll get to that in just a moment. And in fact, that's coming right up, so we'll get to it. We saw Bill Gates talking about pandemics in 2015. For those of you who have a business background, MBA background, you'll know that Harvard Business Publishing publishes a lot of the case studies and articles that we use in our courses. Harvard Business Publishing published a 160-page paper in 2008 called Business Preparedness for a Pandemic. And it gives businesses a sort of page-by-page description of what to do when the next pandemic comes along. And this is taken directly from the introduction to that paper. There's little argument among the scientific community about whether a future pandemic will occur. And then they go on to say that detection in Asia on one day could trigger pandemic plans in the US the following day. And they even give a quote that a severe pandemic could cause the global economy $3 trillion of damage. Which is all, of course, what has come about. So a lot of infectious disease experts have known this was going to occur. We, both as a world but also as a country, did not do a very good job in preparing for something that everyone knew was coming. So, so microbiology 101, we won't cover a whole lot. Everyone sort of knows what a bacteria is. It's a living small cell. There's about 30,000 bacteria that have been described but we know and estimate that billions exist. And to give you an idea, in a liter of seawater, so a quart of seawater, there are about 1 million bacteria. So if you were to drink that quart of seawater, you would be drinking 1 million bacteria. And about 90% of your body's cells are bacteria. Bacteria are smaller than the cells that make up your skin and your organs. So about 90% of your cells that you're walking around with are bacteria, but they only make up 10% of your weight, which is still impressive. If you take your weight and multiply by 10%, that's how many bacteria you're carrying around at any given time. Viruses are different. For starters, they're much smaller. You can't see them with a light microscope. And they are not, by most factors, actually alive. They do not reproduce by themselves. They are simply a packaged chunk of DNA or RNA inside a protein package. And they only reproduce if they enter a cell. And then they use the cell's machinery to make more of themselves. About 6,000 have been described in detail. Again, we know that billions of these exist. By comparison, a liter of seawater has about 100 billion viruses in it. So it gives you some idea of how ubiquitous they are. They are in the soil, they are in the water, they're in the air we breathe, they're constantly around us. And these bacteria and viruses cause pandemics on a fairly regular basis. They've been with human civilization since the beginning. Some of the first plagues were described early in the Roman Empire. Of course, they didn't know what was causing them back then. We know now they were caused likely by bacteria. And this is a chart that shows some of the bigger pandemics over the years. Smallpox in the 1500s killed 56 million people. Yellow fever, the Spanish flu, which was the 1918 flu, which wasn't Spanish at all. You should read up on it if you haven't already. Killed between 40 and 50 million people around the world. It was our last big flu epidemic. On this chart is the HIV/AIDS epidemic, which has killed between 25 and 35 million people in the world. And is ongoing. But you'll also notice there was Asian flu, Hong Kong flu, SARS, swine flu, Ebola, MERS, and now COVID-19, all which have come about in the last 100 years or so. In fact, mostly in the last 50 years. So the question is, why are we having more pandemics now than they have in the past? Or why does it seem like we are? And that gets us into the area of emerging infectious diseases, which are new diseases that occur or ones that were very constrained to a certain population or area and now are expanding rapidly. And the World Health Organization keeps tab of these, obviously. And since 2007, they've seen more infectious diseases emerging than they have at any time in the past. Since the 1970s, about 40 new diseases have been discovered, infectious diseases, and that's SARS, MERS, Ebola, avian flu, Zika, and now COVID-19. And the reason for this is multiple. One is travel, so people are able to spread these diseases around more than they could in the past. Population density, we live in these megacities now where we're able to spread an infection between ourselves much more easily. And we're forcing wild animals into close proximity to people and constraining the wild animals to narrower ecosystems, which makes it more likely that a virus can spread from an animal to a human being. And in fact, there's evidence that putting stress on the animals makes them more susceptible to viruses, which then can be transmitted to humans. So viruses typically jump from some sort of animal to humans. Measles are believed to have come from cattle before recorded history. Smallpox came from either primates or camels about 10,000 years ago. Ducks are where flu came from. And flu's been around for a long time, but was first sort of characterized in 1910. Ebola was a bats to human transmission, and the SARS-CoV infections are moving from bats to what may be civets to humans. Civets are sort of a cat-like animal that lives in Asia. This is a complicated chart, and I'm not going to spend a lot of time with it. It just gives you an idea of some of the diseases that the World Health Organization is watching on a day-to-day basis, waiting for these to break out and become worse. Crimean Congo hemorrhagic fever has been around since about 1200, but it's in the Balkans and Africa and Asia. Every year, some people come down with this. It's got about a 25% fatality rate. Ebola virus was first described in 1976. It has a 25 to 90% death rate. Marburg virus was first became a problem in Germany and Yugoslavia, but actually comes from Africa. 25 to 100% death rate. Nipah and Rift Valley fever. All of these are fairly deadly diseases, and they have spread around the world. They're now in multiple places. Zika has been around since 1947, Africa and Asia primarily, but now has moved to the Americas and is now more of a problem, partly because Americans became more aware of it. It rarely causes death, but is known to cause severe birth defects. And these are all the emerging viruses they're watching, or some of them. And that does not even include the HIV/AIDS, tuberculosis, malaria, bird flu, dengue fever, things that are endemic and do cause massive death and disability around the world. So there is a lot of disease around the world and a lot of very dangerous stuff that can spread. All right, so the COVID-19 pandemic, technically it's a SARS-CoV-2 virus. SARS is severe acute respiratory syndrome. When your lungs become infected, you develop a severe respiratory problem beyond what is normally a typical pneumonia. COVID stands for coronavirus 2019, which is when it was first described. Again, we think it jumped from bats through an animal vector to humans. These viruses are constantly mutating. The genetic material, there's so many of them, and they are constantly changing. And if a mutation suddenly makes a small group of them more contagious, then that becomes the dominant species of that virus. It's transmitted by fomites and airborne. Fomites are the fancy medical word for when you touch something and then someone else touches it. And it causes everything from no symptoms to viral pneumonia to multiple organ failure. And so doctors have been trying to figure out where the coronavirus sits. This is an older chart, so they have a little bit better information now, but it gives you an idea of what they're trying to estimate. So from left to right is how contagious various diseases are. So chickenpox is fairly contagious. On the y-axis is how deadly a disease is. So chickenpox is not very deadly. SARS and MERS were much more deadly and somewhat spreadable. It's interesting that these play off against each other. So if an infection is very deadly, what it'll do is kill all the people that have it, and so it doesn't spread very well. If a disease is very infectious but doesn't cause much disease, then much symptoms, then it may spread a lot, but we don't get very concerned about it. That would be like the common cold. The worst scenario is when a virus is both very infectious and causes significant morbidity and mortality. And that seems to be kind of a sweet spot that the new coronavirus has hit. It's much more contagious than the regular seasonal flu, and it's much more deadly. This is a three-dimensional imaging view of a person with COVID-19. This is a view of their lungs, and it's been colorized so that the stuff that's yellow and green is the COVID-19 diseased lung. And so doctors have been surprised that, typically when you get a pneumonia, you get it in one part of one lung. This pneumonia seems to spread throughout the lungs and causes a massive amount of disease. There is also some real concern now that a lot of the changes in the lungs, once you've had COVID-19, are permanent. So you don't get this function back, or don't get all of it back once you've recovered from COVID-19. So it's a very serious respiratory disease. For those non-medical people watching, if you have severe lung disease, the first thing you can do is get some oxygen through a nasal cannula. That can increase your oxygen levels some. Room air is 21%, and nasal cannula gets you up to about 40%. If you need more oxygen than that, then that's when you use a face mask. That can get you up to about 60% oxygen. In people with COVID-19, not only do they need oxygen, but their airways are actually collapsing. So that's a CPAP machine on the right, which is used for snoring and other problems of airway obstruction, but those are being used on COVID patients to keep both an oxygen level up and also to keep the airways open. If you go beyond that, that's when you're intubated. And again, for the non-medical people, what you do is you take an instrument called a laryngoscope. It's a sort of metal blade. You can do this. There are more high-tech ways to do it, but classically you would take a laryngoscope and you would take a endotracheal tube and thread it down through the mouth into the trachea and blow up a balloon. And then you're able to literally blow up the lungs and let the air out of the lungs like you would be blowing up and letting air out of a balloon. And you hook that to a machine, which is the ventilator. By the time you get to this level, though, you need all the equipment on the right. So you need a lot more intensive monitoring and care. There's been a lot of description. This is just sort of background information about personal protective equipment. It's not fancy. This is just very simple, sort of a paper cloth type aprons, it's gloves, it's masks, and a face shield and booties. This is very simple, sort of routine healthcare equipment. You only use it once you're done taking care of an infectious patient. You take all of that off in a room that's used for putting on and off sterile equipment. You take it off carefully and you throw it all away. So the reason that healthcare providers are burning through so much PPE is simply that if you've got a hospital full of COVID patients, you have all of your employees putting on and taking off PPE multiple times a day, and you do go through a lot of it. Most patient care doesn't require this degree of personal protective equipment. So that's the PPE that everyone's talking about. Again, not very high tech, but being used in large amounts. There was an article recently by the Singapore University School of Design that I thought was interesting. It described the 4 horsemen of the COVID-19 pandemic, why this pandemic is more severe than other pandemics in the recent past. Number 1, they talk about overpopulation. 2, globalization, that we're spreading and traveling so much more than we used to. 3, the hyperconnectivity, and 4, the very tight supply chains. And the combination of those 4 things is making what would be a very bad virus into even a more significant problem. And they describe that this is maybe a nonlinear dynamical system of a fragile, volatile, hyperconnected world. So we may have reached a population and population density level in the world that's not been seen before, and that predisposes us to pandemics going forward. And so this has been described as sort of the new cruel normal. It's going to be about 3 years, probably, realistically, until herd immunity develops or a vaccine's developed, at least on a worldwide basis. Herd immunity is when so many people have been exposed to the virus, had it and recovered, that the virus has no place else to go. And that's anywhere from usually 60 to 90% of a population. There are about 100 different types of vaccines that are being produced currently, and those may be available sometime next year. They may not be. Some diseases we don't have any vaccine for. So I'll take maybe one quick question, and then we'll go on to the third module.
Yeah, so we had a question. So I've seen telemedicine being prevalent during the crisis. How would billing work for these remote practitioners in the volume versus value system? Also, will elective healthcare practitioners like dentists, podiatrists be in similar situation as the MDs, the DOs?
Yes. So all healthcare practitioners are going to end up using telehealth a lot more than they have in the past. The billing is straightforward. Just as you have a patient encounter and the doctor documents something and that gets turned into a bill that someone pays, in telehealth, the doctor or nurse practitioner or whoever is delivering the healthcare talks to a patient, makes some decisions, makes some notes, and that's turned into a bill. So it's really not a billing problem. Can there be fraud? Yes, but there can be fraud in healthcare under usual billing systems. And we'll talk about it in a minute, but telehealth is going to be one of the major new changes that will become part of healthcare in a much bigger way now than it was before. So what I want to do is finish up with a few ways that the COVID-19 is affecting our healthcare system. We talked about quality, and there's a huge mismatch of resources, and in some cases inadequate resources in terms of bed, personal equipment, protective equipment, ventilators and such. We're reusing disposable equipment, we're sharing ventilators, and we have healthcare practitioners that are trying to work when they're either burnt out or maybe even becoming ill themselves. And so quality is going to suffer. Cost is going to be tremendous. So there's a lot of question about who pays. There's a lot of expensive ICU care involved in COVID patients, and you're losing an enormous amount of money from increased labor overtime. And more interestingly, perhaps, the hospitals caring for COVID patients are unable to provide all of their elective and non-emergent care. And this is having a really detrimental effect on the healthcare system. And finally, access, we talked about, was a healthcare system problem before COVID-19. And again, the system now is showing all of its inequities and inequalities on geographical lines, age lines, racial lines. The best way to think about the healthcare system in COVID-19 is not that COVID-19 is some vastly interesting new problem disease. It's basically an illness that doctors know how to care for, although there are currently no vaccines or drugs for it because it's so new. But it's a disease that doctors and hospitals know how to care for. The problem is that it's a massive stress on what was already a costly and not entirely efficient healthcare system. This has been disruptive for patients. They're not getting preventive care. They are not going for even urgent healthcare. The number of strokes and myocardial infarctions showing up in emergency room is down 40%. So people, it doesn't mean that COVID is somehow curing people of stroke or myocardial infarctions. It means that people are having strokes and minor heart attacks at home rather than risk going to the emergency room. So we are deferring a lot of standard care when hospitals are either full or when they're seen as too dangerous to care for anything but a life-threatening COVID infection. It's been disruption for the providers. The places where COVID's been prevalent, there's a lack of ventilation equipment, of protective gear. It's an enormous stress. And to give you some idea, at Mayo Clinic last month, it's a $12 billion revenue type organization. They're facing a $3 billion loss through the end of 2020. And so they're deferring things and drawing down their financial reserves. More dramatic, perhaps, if you look at job loss in March, the number of healthcare job losses was 43,000. And amazingly, in April, the healthcare system lost 1,400,000 jobs, which you would think during a COVID crisis, if anything, more people would be employed in healthcare. In fact, healthcare systems are laying off healthcare providers in droves to care for just the COVID patients. These are job losses that will take a long time to make back up. And in terms of health inequality, the numbers are pretty horrific. For instance, in Louisiana, people who are Black make up 70% of the deaths, although they're only 33% of the population. In New Mexico, Native Americans are 20% of the cases on 5% of the population. So the people at the lower income levels are really getting hurt by the COVID-19 crisis. And this makes sense. One study's found that on a Navajo reservation, 30% of the homes do not have running water. So you're not going to be doing a lot of hand washing when you don't have running water. So briefly, 7 healthcare problems to solve. These are all for-profit and not-for-profit and volunteer opportunities for people who are interested in COVID-19 and the healthcare system. 1 is the testing and contact tracing. I think all of you are familiar with this. We need to test everyone over and over and isolate the people with infections and track all their contacts. And this, even the technology is not going to help us much with this. This is just brute legwork and interviewing people. It's going to be an enormous job. It's the only way that COVID will get shut down and constrained. Second, dealing with some of the health inequality. We need to focus more on prisons, homeless, evictions, nursing homes, and make sure that all of the testing and contact tracing, if anything, is better for those who are in lower income brackets, because that's the group of people that will be hit most, and they're our neighbors. I mean, so this is a very good time for the U.S. to really focus on how we're providing healthcare to people in a disadvantaged situation. The solvency of providers, Congress has allocated $170 billion in payouts to healthcare institutions. Hospitals are, though, losing $50 billion a month. Interestingly, the majority of that is revenue from lost elective procedures. So this is deadly. The average nonprofit hospital has an operating margin of 2%, so they just can't sustain this kind of loss. And you're going to have, with hospital closings, it's going to be very important to open hospitals as efficiently as possible, and probably instead of one-time payments, expanding Medicare and Medicaid. Hospital safety and adaptability. Hospitals need to start thinking now about workplace design, incorporating telemedicine, using more robots and drones in a way that they can take care of a surge of infectious patients. The healthcare supply chain, and that was the last question we got, was the basic problem is either lack of supplies, the PPE, or the supplies are in the wrong places. We have enough ventilators, but they're not where the coronavirus currently is. So supply chain experts are going to focus a lot in beefing up supply chains. A lot of this will involve data sharing among healthcare providers, and IBM, I think, has already come out with a blockchain solution they've suggested. Local production of some of the PPE might make sense in a place like the Texas Medical Center, where so much is used. You could always sell the excess. Supply sharing will be important. Stockpiling, perhaps less. A stockpile doesn't do you much good in today's economy. What you want is a stronger supply chain. Provider mental health. Doctors are used to losing patients from time to time. Doctors are not used to losing patients at the rate that some of the New York hospitals have been losing patients, and this has led to concerns about post-traumatic stress disorder type problems in areas that have been hit hard by COVID. So it's going to require a lot of leadership among the healthcare institutions and a lot of care of their healthcare personnel, and ultimately increasing resources for mental health. And lastly, telehealth needs to be rapidly scaled up. A lot of healthcare is answering questions that can be discussed and diagnosed and prescribed through telehealth. And perhaps only a smaller proportion of patients actually needs to physically come and be looked at by a physician or be cared for by a physician. This is especially important in places that are medically underserved. Creates a possibility of a virtual hospital where all the experts are simply working in front of screens and diagnosing and treating a large number of patients that can be treated through telehealth. And there will need to be more diagnostic and monitoring designs for home health. So that in a very rapid way, we've covered both the U.S. healthcare system. We've talked a little bit about COVID-19 and what it is and why it's causing problems, and then some of the effects on the U.S. healthcare system. So if we have time for another question or two.
Well, so we could stretch this a little bit if you had a few minutes. We do have quite a few questions. Sure. So if you're okay with it, we'll, okay. Those who need to drop can drop. And for those who are interested in some of the questions, you're welcome to stick around for a few more minutes. Okay, so I won't be able to get to all of them, but let me give you a few of them here. So you mentioned that monetary shock to the healthcare system that COVID is creating. Do you think this is going to cause insurance costs to skyrocket over the next few years? Do you expect drastic changes in the health insurance industry because of this?
All right, so the healthcare insurance industry is unique. So you might think that in a COVID-19 pandemic, healthcare insurers would be getting killed. In fact, just the opposite. They are drowning in money. And the reason they have so much extra income is they're not paying for all of the elective care. They're not paying for all the sort of routine hospital care and ER care and doctor visits. So all of a sudden, healthcare for everything except COVID-19 has dropped off dramatically. And so all of a sudden, healthcare insurers are flush with money. They're required under federal law to give back any money beyond a certain point of administrative cost. And so you'll be seeing in the coming month or two, healthcare insurers giving money back and making donations and what have you, because they're basically required to do such after they reach a certain profit level. So for the short term, healthcare insurers are going to be making a lot of money. That as hospitals are able to adjust and reopen, and this backlog of healthcare can't wait forever. As hospitals begin to return back to a more normal situation, then the healthcare insurers will be paying for the routine care, the elective care, and the COVID-19 care, which arguably could be a lot more than what they had and were dealing with before. Again, so many of the people struggling with COVID-19 are actually uninsured. So how it actually plays out over the next year or two is something I'm sure healthcare insurance executives are trying to figure out right now. If it in fact becomes more expensive, then all the healthcare insurance rates will be going up next year.
All right, so this question is, will it be 3 years until we have a vaccine? Companies have come out with much more aggressive projections. For example, Q1 2021 was one we heard recently. Are you skeptical that they will deliver on this?
I am skeptical. First off, it's really difficult to develop a vaccine. So the experts will tell you that to develop a vaccine in 18 months has never been done before. And to give you an idea, SARS, MERS, Ebola, there's no vaccine for those diseases. So they've been around a long time. They're deadly. We know they exist, and we've never been able to develop a vaccine for them. Coronavirus is one of the viruses that causes the common cold. And we've never developed any sort of vaccine for the viruses that cause the common cold. So first off, there's an open question whether it's technically possible. On the other hand, the world's never thrown this much money and intellectual thought at developing a vaccine. So there's currently about 100 vaccines that are going through trials. What I think you need to be careful about is every day you're going to hear about a new possible vaccine, a new possible drug. And the companies that are making these vaccines and drugs are trying to get investors, trying to get funding. And so they're all going to be trumpeting their early successes or possible successes. The actual difficulty of finding a vaccine that is proven to work and then distributing that to hundreds of millions and ultimately 4 or 5 billion people is a huge undertaking. I don't think the world's ever tried to do that before, anything close to it. So I'm skeptical. I think there's a 50-50 shot we have some vaccine that might work come early first quarter of next year. Is it possible we'll have a widely distributed one by the end of next year? It's possible. But remember, if we don't treat everyone in the world, the infection is going to keep coming back. So I think if I was a business planner, I would look at a 3-year model. After 3 years, herd immunity sort of does kick in by all the models. So one way or the other, in about 3 years, we should have a better handle on this. If we're able to develop a vaccine in a year or a year and a half, then that would be wonderful. I don't think you can bank on it.
Or not quite 5 over, maybe just one or two quick
Sure.
questions, see if we can go through them.
Yep.
Can you explain if someone has the antibody and what that actually means? Do they get it from getting COVID-19 or do they have it prior? What percentage of the population, any guess, might have the antibody at this point?
So to throw out some medical words, antigen is a piece of the virus. So an antigen test tells whether or not you currently are infected with the coronavirus, and there are a number of those that exist. Some of them are maybe not as accurate as we'd like. An antibody test is looking at a person's immune system to see if they've developed a reaction to having the COVID virus. So if you have antibodies to the COVID virus, it means that you had COVID at some point. You may have been asymptomatic. So they're not only trying to develop antigen tests to determine who is actively sick with COVID-19, they're also trying to develop these antibody tests. Theoretically, they should tell you who's had COVID-19 and who may therefore be immune. One of the big questions, though, and it's not been answered yet, is even if you have antibodies against the COVID-19 virus, it's unclear whether that gives you long-standing immunity. There are a lot of immune responses that give you immunity for a few years, 2, 3, 4 years, and then you're no longer immune. So a lot of questions. It's a great question. Doctors don't know the answer to a lot of that.
All right, so we have seen the hazards of not having enough PPE and not really being prepared for an outbreak or events like this. How should hospitals and other facilities approach preparing for the next big scenario? This pandemic has exposed a significant flaw in our system. What's next? What do we do?
So the 7 things I mentioned. So we need to have hospitals that can be perhaps more easily configured for an infectious outbreak. We have to have supply chains that are more robust so that when an outbreak occurs in an area, we rapidly are able to bring in ventilators and PPE from outside to take care of patients. Ultimately, though, the answer is more funding for the World Health Organization, more investigation, and very, very quick responses when any sort of outbreak occurs in any part of the world. So it truly has been demonstrated now that this is basically an existential threat to both the lives of people in the United States as well as our economy. And a lot of effort should be put into making sure once we get through this pandemic that we're ready for the next one. So
the question here, is it reasonable to open up the economy now? Some people do not practice distancing or use masks. What's your take on that?
So that's a great question. So I've tried to explain it to people like this. This is not a maybe not type thing. This is sort of a force of nature event. It's like if you're in a sailboat out on the ocean and a big wave is coming, the big wave is going to come, and there's not a lot you can do about it. And the coronavirus spreads from person to person. That's how it is maintained. So if you are in close proximity to others and one or more of those people has coronavirus, it's going to be spread. The more distancing you have from other people, that slows the spread of coronavirus and gives healthcare workers and scientists longer time to better be able to care for the large number of patients that still will ultimately come down with the illness if a vaccine is not developed. But there's a direct, and if you watch, there are states and countries now that are reopening back up, and if you watch their infection rates, you'll watch their infection rates start to trend right back up according to the degree of which they've opened. And so it's a devil's bargain. The more you open the economy, the more coronavirus you're going to have. And I think most experts in the area, I'm not one, but most experts in the area of infectious disease believe it's essentially a foregone conclusion that we're going to have a resurgence of coronavirus around the world this fall for a variety of reasons. So there's no question that social distancing and keeping things closed ultimately reduces the number of people getting coronavirus. And the more you open, the more coronavirus you're going to have in your community. It's just going to be a matter of time.
All right, last question, and then we'll do a wrap up here. So you mentioned the WHO, World Health Organization. The question is, what does the WHO do that the CDC cannot do? What's that value proposition?
Oh, that's a great question. So the CDC is effectively the World Health Organization in the United States. So the CDC is a U.S. entity. It is a U.S. government agency that is tasked with identifying, following up infectious diseases, along with other types of diseases. And so they have the lead role in the United States, but every country has a CDC type agency, and then the World Health Organization is sort of the world body that brings together all those individual country agencies to provide a more unified response. So excellent question.
All right, I think we should probably wrap it up. Thank you so much,
Thank you all for
Edward.
Watching tonight.
Fantastic. All right. So, first of all, big thank you to Edward Kroger for cutting out some time this evening to give us some insights. A huge thank you to all of you who joined us. Keep an eye on the upcoming programs here at Rice at the Business School and Exec Ed. They'll be coming to you, hopefully some live, but quite increasingly online or blended. Come join us on campus. Most importantly, stay safe, stay healthy, but stay engaged. Thank you so much. Good night, folks.